Welcome to Optometric Education Consultants webinar series. Tonight our topic is Ocular Melanoma, a comprehensive review. And it's really my great privilege and pleasure to introduce Dr. Carlo Pelino, a graduate of the Pennsylvania College of Optometry, where he also completed a residency in ocular disease at the JFK Memorial Hospital in Philadelphia. His concentrations were retinal neuro-ophthalmic disease. He additionally completed a retinal fellowship emphasizing medical and surgical treatments under the direction of vitreoretinal surgeons at Crozier, Chester, and Riddle Memorial Hospitals in suburban Philadelphia. Currently, Dr. Pelino is a full-time assistant professor at the Pennsylvania College of Optometry and lectures in the Retina and Clinical Medicine courses in both the traditional and accelerated scholars program. He's also lectured at other programs within Salus University. He currently serves as the Director of Optometric Retina Service, the Eye Institute, and Chief of the Chestnut Hill Primary Care Clinic. He's a fellow of the American Academy of Optometry, and he was the chair of the Retina Special Interest Group of the American Academy of Optometry. It's not very often I get to hear Dr. Pelino talk, but I have it in the past. I'm very, very just impressed with how smooth his delivery is, how well researched his material is, and combined with his clinical experience, it's really a pleasure for me to be able to host him and attend the webinar. So with that, please give a virtual round of applause and welcome to Dr. Carlo Pelino.
Thank you, Joe. Thank you, everyone. It's my pleasure to be here tonight, and I look forward to giving this lecture. And I'm happy that we're going to do some poll questions, and we'll take some of your questions at some point. So I'm going to go at a nice pace, and I hope you get a lot out of this, and I hope tomorrow you change maybe a little bit how you practice from this lecture. So with that being said, let's move on and let's start the COPE slide here so we can get into the meat and potatoes of the lecture. So the content of this COPE accredited CE activity was prepared independently by myself. I have no direct financial proprietary interest in any of the companies, products, or services mentioned in this presentation. The content and format of this course is presented without commercial bias, and it does not claim superiority of any commercial product or service. And as you've seen in the first slide, this is Ocular Melanoma, a comprehensive review. So what I'm going to do, everyone, we're going to talk probably about the first 70% of this, maybe less, maybe the first 55% of this lecture will be on the eye. And then after that, we're going to get into some molecular genetics and biochemistry and so forth. And we're going to look at it from a medical oncology standpoint. So basically, how are we going to diagnose this condition? What are its differential diagnoses? What's the eye treatment? And then what are we going to do, or what's the process to keep the patient alive, specifically if this metastasizes to the liver? So that's how we're going to approach this lecture tonight. So you can see from this particular slide, what's the definition of a tumor? It's also called a neoplasm. And it's a new growth of tissue characterized by a progressive, uncontrolled proliferation of cells. The tumor may be localized or invasive. It could be benign or it can be malignant. So before I continue with this slide, a choroidal nevus will be benign tumor. If it turns into a melanoma, you have a malignant tumor. So these neoplasms can be these tumors can be named for its location, the cellular makeup, and for also maybe a person that found it, it could go under their name as well. So we're going to look, as I said, into these benign tumors. We're going to look into malignant tumors and so forth. Now, if you look on this slide here with the list of tumors that can occur, this is a whole lecture in itself, but we're going to focus on the choroidal nevus. We're going to focus on the choroidal melanoma, which you see up the first few that are mentioned. At the end of the lecture, I will go into some differential diagnoses. and that will be congenital hypertrophy of the retinal pigment epithelium. We will look at choroidal metastasis. That's way more common than a choroidal melanoma. Choroidal metastasis, mainly breast cancer, women, lung cancer, men. They could look a little similar to the melanoma, but I will show you some things here that I think are going to be important, but that will be at the end of the lecture. And then you can see here, melanocytoma, I will show you that. That's a magnocellular nevi or nevus that can become a melanoma. And there are others here that we will not talk about tonight. So there are many ocular tumors that can present in the eye, but I'm going to focus mainly on the choroidal nevus and the genetic patterns that turn it into a choroidal melanoma. So let's look at melanoma in general. So if you look at the right of the slide, you see the choroidal melanoma. So we're going to look at the uveal tract. Choroidal melanomas make up approximately 90% of the tumors, the melanomas that present in this uveal tissue. Remember, the uvea is the choroid, the ciliary body, and then the iris. The melanomas of the ciliary body, those can be tougher to find. That's why when you're doing your dilations, you really have to end every view in the ciliary body, the pars plana. Those make up about 5%. And then the iris melanoma is the remaining. So obviously we're going to look at the choroidal melanoma, as I told you previously, but please remember, because the ciliary body melanoma is tougher to detect, they can be deadly. All of these can be deadly because of metastatic lesions that end up mainly in the liver. But because the iris melanoma is easier to be found or earlier to be found, they are less deadly. But the choroidal melanomas and the ciliary body melanomas, pay close attention on your dilation to make sure there's not a nevus there, because that nevus, depending once again on its genetic pattern, can turn into a melanoma. Now, what you see on this particular slide, you see, let's look at the left part of the slide first. You see you have a conjunctival melanoma. The precursor to the conjunctival melanoma is something called PAM, P-A-M, primary acquired melanosis. So if you're observing a person in clinic, in your office, and you notice, wow, I have this, which will start out as a flat colored, let's say, lesion, that would be primary acquired melanosis. That can then transform into a conjunctival melanoma. Then you have what you see in the bottom left, a cutaneous melanoma. And that can occur obviously anywhere on the body. Let's concentrate, let's say, in the face area. And then you see what we're going to talk about tonight in the upper right, and that is a choroidal melanoma. Now, why did I put these up here? I put them up here because not all melanomas are created equal. They are not. All three of these have a different genetic pattern, and I will show you in the slides coming up. All three of these have a different genetic pattern for growth and malignancy and metastasis and death. And so what is important to remember, that the conjunctival and the cutaneous melanoma, they may have a correlation to ultraviolet light. The choroidal melanoma does not. The choroidal melanoma, for the most part, has nothing to do with the amount of sunlight you get through your lifetime. The epigenetic factors for choroidal melanoma, I will go over. So before we move on, let's look at what's on this slide as well. Updated ways to diagnose uveal melanoma. So we're going to go over that. New treatment plans. I'm going to show you these checkpoint inhibitors, which are wonderful to keep the patient alive. We will look at the most up-to-date RNA sequencing called gene expression profiling. And then once again, I'm going to look at different checkpoint inhibitors and other medicines that are for the liver metastasis from a choroidal melanoma, known as adjuvant treatments. So before I leave this slide, everyone, what I would like you to look at in the patient in the upper right, that started as a choroidal nevus. And the choroidal nevus is a benign tumor, and it has to be followed appropriately. And if it's not, if the patient doesn't understand the severity of it and the doctor just kind of brushes, if the doctor doesn't pay close attention, you end up with what you see here. And what I wanted you to know about this particular patient that you see in the upper right, you see the melanoma does not go through the fovea yet, but the exudative detachment does. The fovea for tonight's lecture, everyone, is the same size as the optic nerve, 1.8 millimeters. The macula is much larger. That's about 5.5 millimeters. That's almost the size of, you can see it drawing a circle inside those blood vessels of the posterior pole. That's the macula. So the tumor is in the macular area, but not in the fovea. But the exudative detachment is. And so the patient presented with metamorphopsia, and then you see, this is the first time I'd ever seen the patient. Another eye doctor on the outside had seen the patient before, and then you see the large melanoma that's found upon dilation with an exudative retinal detachment through the fovea. So that being said, the percentages of these melanomas are what you see here. We showed you, or I showed you, the percentages of the uveal melanomas, the choroidal, ciliary body, and iris. Now I just want you to look at the percentages of the three that I just showed you before. Uveal tract melanomas are 95% of the melanomas. The conj are about 5%, 4%, and the orbit and the eyelid cutaneous melanomas are about 1%. So that gives you an idea of what we're going to be talking about tonight. And here's the first slide to talk about genomics. Now, because we're talking about cancer, we have to look at genomics from two standpoints. We have to look at genes that are oncogenes that turn the tumor on. And then we also have to look at genes that are tumor suppressor genes. Those genes are missing, and it also turns the tumor, or it allows the tumor to progress or proliferate. So we have oncogenes and we have tumor suppressor genes. For those of you that are familiar with breast cancer and BRCA1 gene and BRCA2 gene, those are tumor suppressor genes. They're not oncogenes. So when we look at this particular slide, everyone, we are looking at oncogenes. And you can see that the cutaneous melanoma, the skin melanoma, is BRAF. Cutaneous melanoma is also NRAS oncogene. Those are stimulated, those are turned on. Mucosal, right, the conjunctival melanomas are c-KIT oncogene. And the one that I want you to remember for tonight that leads a melanocyte of the choroid. Melanocytes of the choroid are from, as you remember, neural crest cells. Melanocytes, if they have a GNAQ or a GNA11 oncogene, and there are more that I'll show you coming up, they are the ones, those individuals will then get a nevi or a nevus. So you can see here, that's why I spent some time with this particular slide, everyone. They are all different in oncogene etiology. And so once again, before I leave and move on, please remember, if a choroidal melanocyte has a GNAQ or a GNA11 oncogene, it doesn't mean it's going to turn into a nevus, and it doesn't mean it's going to turn into a melanoma. The epigenetics will determine that, and I'll show you what the epigenetics are coming up. GNAQ and GNA11 oncogene are the first genetic let's say, mutations that allow a melanocyte of the choroid to at least turn into a nevi or a nevus. I will give you the rest of the genes that go into melanoma state and metastasis state coming up.
Hey, Carlo, this is Greg. I got a question
Yes.
for you now.
Yes.
I'm in primary care a lot. I'm in Western Central Pennsylvania. We do a lot of, wellness programs, optomaps, dilation, of course, so on and so forth. And we see nevi all the time. Is that fair to say that they have then the GNAQ or GNA11 oncogene? Is that fair to say that anytime I see that, that's what they have?
Yes. The answer to that, Greg, is yes. There's a few slides coming up. 95% of choroidal nevi will have the GNAQ, GNA11 oncogene. The other 5%, Castle Biosciences just discovered it, and I'll give you that other 5% of those other genes coming up.
Perfect. Thanks, Carlo.
You're welcome. You're welcome. So, but those are like Dr. Caldwell said, the GNAQ and the GNA11 are the primary drivers, the oncogenes. There are a few others that I will bring up to you. Basically, there are two others that just recently were found, but in lower incidence / prevalence. So before I get into some more of this, this is a wonderful histological slide of the retina. You all know that the retina is a clear, transparent tissue, and it only has color to it mainly because of the choroidal system, the blood vessels of the choroid, Haller's layer, Sattler's layer, choriocapillaris. But it has color to it. The retina appears to have color to it because of the melanocytes that are located in the choroid. And here's the interesting thing. Here's what I find extremely interesting. If you look at this particular histo slide, and I don't know, maybe Joe or Greg, can you see my arrow? Is my arrow present?
It is.
Okay, thank you. If you look where my arrow is, here's the retinal pigment epithelium. And it's pigmented because it has melanocytes in it. No matter what race you are, we will all have the same amount of melanin in the RPE. The melanin differs in the choroid. So if you are of African descent, you're going to have more melanocytes. If you are Caucasian descent, you're going to have less melanocytes. And what I find interesting is that the Caucasian population, about 80 to 90% of all choroidal melanocytes, 80 to 90% of all choroidal melanomas are in Caucasians. So they have less melanocytes, but they must have a different genetic pattern. And I'll show you that coming up. So we're going to look at this melanocyte as obviously the etiology of a nevus and the etiology of a melanoma and the genetic pattern to get this melanoma. And what I wanted you to understand as well, they can grow rapidly because the choroid is probably one of the top two areas of blood supply in the entire body. So they can grow, they get the nourishment that they need. And then I'm going to explain one other thing coming up about immune privilege and how smart these melanomas are to evade the immune system to live. So we are going to talk about that coming up. Here's your basic melanocyte again. The melanocyte, as I said, is from neurocrest origin. And the melanocyte, this one happens to be in the skin, as you can see, the keratocytes and the melanosomes. But the melanocyte will make melanosomes. And you can see here in this particular picture, you can see the nucleus, you can see the mitochondria and so forth. And that's very important because when I talk about the genetics of melanomas, you can see this is where we're going to focus on. Now, let's take a step back first, everyone. This is an extremely important slide just for cancer in general. Every one of us tonight on this webinar / lecture, every one of us has cancer. The reason it's not out of control is because you all have an intact immune system. You have a very strong natural killer cell, and you have a very strong CD8 T helper cell. Those two will find the cancer cells and they will eliminate them. When cancer beats those two systems, the natural killer cell, remember the natural killer cell is very interesting. The natural killer cell is out of the lineage of the T cell and the B cell, but it's not in the adaptive immune system. It's in the innate immune system. It's very interesting. The natural killer cell and the CD8 T helper cell will find these cancer cells and eliminate. If they can't, they grow. But what I want you to remember from college, right, basics of the cell cycle, college, optometry school, you see the cell cycle. It starts with G1, the gap phase. It goes into the synthesis phase where the DNA is going to be replicated. It goes into another gap phase. It goes into mitosis and then cytokinesis. Why do I have this up here? I have it up here because remember, this is going on in the cell. Gap 1, synthesis, and gap 2 is all called interphase. That's all interphase. Then once you get into mitosis, everyone, then you get the typical PMAT, prophase, right? Anaphase, telophase, metaphase, all of that. Why is this important? The body has 3 checkpoints in this cell cycle, 3 checkpoints. The first checkpoint is right here between G1 and the synthesis phase. That is called, the checkpoint is checkpoint 1, and its biggest name for checkpoint 1 is the P53 protein. P53 is called the guardian of the genome. The cell knows, the nucleus knows, I will not allow the DNA to be replicated if it is not properly in its sequence. So there's the first one, checkpoint 1. Checkpoint 2 is going from gap phase 2 to mitosis. That's checkpoint 2. We could make this a 2-hour lecture just on this slide. The third checkpoint is in the mitotic phase, in metaphase, where the spindles have to form. If you've got an improper G1 checkpoint, if you've got an improper G2 checkpoint, or you've got an improper M or mitosis checkpoint, cancer will occur. So remember those checkpoints. And P53, I will show you coming up, is the main tumor suppressor gene that's eliminated. So breast cancer, even though BRCA is a breast cancer tumor suppressor gene, P53 that's somehow altered cannot read the first checkpoint, and you will go into synthesis phase. We don't want that. Most of you know there's another protein called the retinoblastoma gene. That's also at the G1. People who have retinoblastoma, it's because of the G1 checkpoint. So keep this all in mind as we talk about not just ocular melanoma, but cancer in general. And here it is. What I really like to show you here, here's the guardian of the genome, P53. It does many things. It reads the DNA. And look at something here specifically, everyone. P53, you see, it will make a protein called P21, and it will shut the cell down to say, fix this DNA before you replicate in the synthesis phase. Now, what's interesting is this. If it cannot be fixed, the cell will then make FAS-APO1, and the cell will go into apoptosis. And that's how this works. P53 is the first checkpoint. You're either going to correct it or you're going to say it's going to die. And melanomas and other cancers, they bypass this because of P53 problems or retinoblastoma gene problems, or the G2 checkpoint or the mitosis checkpoint. P53, please remember, the guardian of the genome. Now, if you look at this particular slide, I'm going to focus on the right part of the slide first. P53 is responsible for greater than 90% of all cancers, okay? And found, as you can see in that percentage, breast cancer, lung cancer, ovarian cancer, colorectal cancer. Now, what's interesting about ocular melanoma, P53 is not one of the main tumor suppressor genes. It's not. It's later down the line. BAP1, BAP1, the BRCA-associated protein gene, is the main driver for metastasis. So even though I'm talking about P53, it's later in the, let's say, road trip. It's not initial. And look at the top statement, 1.7 million cancers diagnosed in the United States. Cutaneous melanoma, about 75,000 cases per year. Ocular melanoma, our topic tonight, is an orphan disease, 2,500 cases per year. It's because it's less than 4,000 cases per year. That's the definition of an orphan disease. So ocular melanoma does not get the money for research from the National Institute of Health, the National Eye Institute, and so forth. So we are going to focus on why is this important? Because the optometrist is the gatekeeper. We've got to make sure that these nevi do not become melanoma. Now, we're going to focus on probably the pianist. So the genes are the piano keys.
Don't hear my move.
And the pianist is the epigenetics, everyone. And what I would like you to look at is the bottom right of the slide. Do you see how the DNA, this is chromatin. Remember, heterochromatin is when the DNA is really condensed, and euchromatin is when the DNA is relaxed. We have to relax the DNA so that RNA polymerase can read the DNA to make a protein. We have to relax it. But this is what's called a nucleosome. When the DNA wraps around these histone proteins, you see these histone proteins. And what is epigenetics? Epigenetics is one of two things. You either put a methyl group on the histone, or you put the methyl group on the DNA. If you put a methyl group on, everyone, it tightens the DNA and the gene is silenced. You don't want to silence a tumor suppressor gene. You do not. So acetylation opens it up. If you put an acetyl group on a histone, it will open it up. So histone methylation constricts the DNA. So does the methylation of the DNA itself. And acetyl groups, so methylation is a CH3. You're methylating the histone and or the DNA. If you acetylate the histone, you open it up. Those are the epigenetic factors that are environmental. If you don't exercise, it may methylate and you can't read a gene. If you eat poorly, it might acetylate. It does both. Epigenetics are the key. You see, that's why if you look to the left, if you want to live a long life and have a good longevity and lifespan and health span, once you hit 40, you don't need a ton of carbohydrate. You don't need, you see insulin-like growth factor, they should all be low. mTOR, mammalian target of rapamycin, your protein should be low because these are the epigenetic factors that will put a methyl group or an acetyl group and change the reading of the DNA. And you know the dogma is to go from DNA to messenger RNA to a protein, transcription, translation. So that's why it's very important with cancer that the epigenetics, the environment, the drugs you take, the food intake, they control the genome itself. And then they can control P53 and so forth. So if you look at all of these three individuals, they all have uveal melanoma, and they're all scary because they're so large here. More than likely, these have already metastasized to the liver. But look carefully, they all tend to have, specifically the patient in the upper right, they all tend to have an orange pigment called lipofuscin or lipofusion on it. Remember, drusen on a nevi or on a nevus, drusen is a good thing because it shows that it's chronic and not growing. Lipofusion shows that this thing is proliferating. And what else is very scary, you'll see coming up, everyone, because there are minimal lymphatics inside the eye, these tumors do not go to the liver via the lymphatic system. They go to the liver by using the bloodstream. And those that are very close to the optic nerve can use the central retinal vein into the cavernous sinus, into the jugular system to get to the liver and live. So what's scary here, please remember this. Any melanoma that's greater than 12 millimeters in diameter, you probably have a 100% chance, that patient has a 100% chance that that tumor is already in the liver. And if nothing is done within a year, that patient will be dead. So that's why the choroidal nevus has to be looked at thoroughly, and it cannot be taken for granted, because they are not going to do a needle, they're not going to do a 25 gauge needle biopsy on a nevi, on a nevus. They're not going to do that to find the genetics of it, to see if it's going to go to a melanoma. They will not do that. So it's the optometrist's role to find these nevi to make sure they are not transforming into a melanoma. The quicker we catch them, the greater chance the patient has to live. So what about the symptoms of, or the presentation of the melanoma, everyone? Well, the presentation, they can be asymptomatic if they're somewhat off of the visual axis. They can have symptoms of flashing or flashing lights, floating objects, scotomas, visual field defects. They can give you a vitreous hemorrhage. Pain is rare. What's interesting is metastatic lesions from the breast, metastatic lesions also from the lung that come up to the choroid, those tend to be painful. And the choroidal melanoma patient is usually systematically well. Now, when you look at this particular, let's say, blood flow, intrinsic blood flow of a melanoma, you can see how much blood is entering this tumor. There are many intricate intrinsic blood vessels within the tumor. And why do I show you this? Because of this that you see in the upper right. The patient in the upper right was not dilated from another outside optometrist, and it was documented as an episcleritis, but they were not dilated. They were given Predforte or some type of steroid drop. It wasn't getting better. It wasn't getting better. It's fine. And then upon dilation later, you can see that why this really wasn't an episcleritis. You can see the melanoma pushing through. This is a combination in the upper right, everyone. This is a choroidal melanoma that has now involved the ciliary body, very dangerous. These are the sentinel blood vessels feeding that melanoma. The bottom right, you can see the melanoma has broken through the iris root. You see the large engorged sentinel vessels, and on the left, another case of these engorged sentinel vessels. So all I'm trying to say here, please dilate. Not every episcleritis is just an episcleritis, and not every sectorial redness is just some kind of pushed aside thing. Look carefully, and please, I'm telling you this from the bottom of my heart. The optomap will not get to always where you have to get. Dilate the patient. Your view should always end in the pars plana of the ciliary body. That's how I know to stop my view. I get the nice transition of retina into the pars plana. I look and you move on. Those ciliary body melanomas can be missed early, and that's why they're deadly. They use the choroidal system to seed into the liver, and then it's too late. So that's a clinical pearl. So
Carlo,
why did I?
Carlo,
Yes, Joe.
Before you get too far, this was an earlier question that we weren't able to get to right away. But you're being asked, how are people on immunosuppressant meds in terms of the oncologic cascade? How is it affecting this oncologic cascade?
So I guess the question is, Joe, immunological medicines in the sense of suppressing the immune system, like Imuran, methotrexate, Cytoxan, those type of things?
Yes.
Yeah, if it's interesting, those particular drugs, so the antimetabolites, right? The Imuran, the methotrexate, the Cellcept, those are antimetabolite drugs. The T cell inhibitors, those are the, they inhibit the T cell in multiple ways. Then you have things like Humira, the biologics, Remicade. What can happen is that could be a very scary combo, possibly, because some of the literature, even though those biologics were looked at, does it increase cancer? If the patient, if it happens to be the perfect storm, if it happens to be something where the patient has a melanoma or is transforming into a melanoma or it's metastasized, it could lead to possibly increasing the metastatic number in the liver. So that's a possibility. It's right now questionable, but it can happen. Yep.
Thank you. Very good.
Okay, thank you. All
Carlo,
four of those.
Carlo, don't forget you have polling questions. Just a reminder. I'm not sure where they are in the lecture, so just a reminder.
Okay. Yep. Thanks, Greg. Thank you.
Yep.
They're coming up. Yes. Thank you so much. So the population here in the United States, you see here, the reason I put this up is what I said earlier. The population who gets choroidal melanoma, the Caucasian population does, genetically driven. 78% of the country is Caucasian. So that's who tends to get melanoma. Can Africans get melanoma descent? Yes. Can Latino, Hispanic? Yes, but a much lower rate. Talking about choroidal melanoma. Even though those races might have more melanocytes in their choroid, there's less chance of melanoma. So what I wanted to show you here, and it's coming up, our first poll question will be coming up shortly. This is Dr. Arun Singh, trained under the Shields here in Philadelphia and is now the Chief of Oncology Services at Case Western up in Cleveland. And he's an ophthalmologist and a statistician. And what he found was he looked at the SEER database and he looked at it and he said, well, melanoma at the most is about 7 cases per million. Males and female about equal, even though males at 52%, female at 48%, whites at 150 to 1 ratio. And the mean time of presentation was about 60 years of age. So that's the SEER database from Arun Singh. The Jefferson team of Carol Shields and the people that Jerry Shields, their database, their statistics are pretty similar. We know that melanoma is the most common primary tumor. You see why they feel, look at the next statement, everyone. They feel that it has nothing to do with UV light because of the fact that the incidence of uveal melanoma has remained the same over the last 25 years. Dermatology has seen decreases in skin melanoma and conjunctival melanoma, but this shows that the UV light probably has not much risk factor epigenetically as the others. Now, here's the key that people ask me. How many uveal melanomas how many nevi, what's the ratio of a nevi turning into a melanoma? 1 in every 8,845, right? Which equals to about 2,500 cases a year. And this is what I said earlier. The diameter of a melanoma equal to or greater than 12 millimeters. You've got a greater than 70, says greater than 70, but it's almost 100%, almost, that you're already gonna have a micrometastasis or a massive metastasis to the liver. And the overall survival is varied based on the genetic pattern that I will show you coming up. So where does uveal melanoma come from? It comes from a choroidal nevus. This is the most common benign intraocular tumor that you will find, a choroidal nevus. You will see this week, if you see 100 patients starting tomorrow, ending Friday, you will see 8 of these, rough estimate. It's found in 8% of the Caucasian population. Now, if you look closely at this particular nevi or nevus, you see the drusen on it. Drusen is a good thing. It shows stability and not transforming into a melanoma. Lipofuscin, the aging pigment, shows transformation. Growth is somewhat rare after puberty. Most of these nevi show up in the 2nd decade of life and in the 3rd decade of life. That's when they tend to show up. And then you have to watch it appropriately. And I'll share with all of you what I've learned from the Shields and what I've learned from the literature. Now, as we age, I just said this earlier, nevi increase in number, and they can increase a little bit in thickness. So watch that carefully. If you have to do an OCT angiography, fundus autofluorescence, Do them. You know, it's legit. Do them. You got to save the life of the patient. You see this particular nevi or nevus? Very dangerous because it's touching the optic nerve. Very dangerous. Metaplasia can occur. And I already went over drusen is safer, usually not transforming into a melanoma. Lipofusion, scarier. The other thing is this, most nevi, everyone, they're less than 2 millimeters. If you see thickness, that's a melanoma until proven otherwise. No known relationship with sunlight exposure. They have indistinct borders, the nevi, and they may undergo the malignant transformation. So I made this term up. There's no such thing as a nevoma. I did it for my students and I did it for my residents so they never forget. Anytime you see a nevus, is it a melanoma or is it a nevus? Make sure you photo document it and measure. And I'm going to tell you right now, and then we're going to take a polling question. I'm going to tell you right now, based off of what the shields have told me and what the literature says, the first time you see a choroidal nevus, you document it. We're going to apply some statistics later. You see it again in 6 months. If it's stable, then you can maybe back it off a little bit and go yearly to every 9 months. The more of these statistics that I'll show you later, the closer you watch it or you punt it. So please don't go home tonight and look up Nevoma ICD-10 code. There is none. All right. Now with that, Greg, let's go to our first polling question, buddy.
There you go. It's lunch for you.
So the definition of a choroidal nevus is which of the following?
And Carlo, whenever that question came in regarding the immunosuppressants, it's when you were going and talking about gap 1 to gap 2 going to the mitotic phase. And if someone was, that's when that question came in. So if someone was on immunosuppressant, you were talking about the natural killer cells. You're talking about the T cell, what is it, CD8?
CD8.
Yeah. So, you know, do those get suppressed, I guess would be the question with
Yes.
these medications.
Yes, that's the key. The cell cycle is not necessarily altered, but those two particular subsets of white blood cells are altered because those are the two subsets that are going to find the tumor cells. Because the MHC, remember MHC1 and MHC2, the MHC1 receptor is less or altered, and those two cell types kind of run over the cell and they say it's altered and kill it. So if they're on any form of immunotherapy and you're suppressing that immune system, mainly, you know, what we said earlier, you're trying to suppress the cytokine response, right? You're trying to suppress the actual number of cells and the cytokine response that's coming from it. So these biologics and these ankylating agents, these T cell inhibitors and these other cells, they're not going to allow the immune system to eradicate this tumor. And that's why you can have some problems. That's why I said it would hit it. It could be detrimental if the patient is getting a melanoma. Perfect. Or a metastasis.
Perfect. Thank you. And then there's your poll results. They're being shared right now.
So the answer is correct. 96% of you got benign tumor that is usually flat or minimally elevated, nothing usually over 2 to 0.5 millimeters in thickness. Very good. Okay, so let's continue on. And let's look at this. If you remember this from school, it doesn't get a lot of attention, but it should. This is the Nevis of Ota. And you remember this is a nevus. This is an increase in melanin, increase in melanocytes in and around the eye. And it includes the intraocular blood vessel layers of the uvea, the sclera, and the eyelids. And what's very important here, if you have a Nevis of Ota patient, the incidence is high for melanoma to occur. melanoma of the choroid, melanoma of the ciliary body, and melanoma of the iris. Okay, so Nevis of Ota is a big risk factor. Now, here are some of the other risk factors to get a choroidal melanoma. I'm going to say uveal melanoma. Caucasian ethnicity, blue-eyed, fair-skinned, tends to burn and not tan, many freckles throughout the body, face, iris nevi, and for some reason, welders. Okay, the arc that's coming from the welding tool. These are all risk factors for choroidal melanoma. Now let's now go into what are the risk factors of, let's look at that nevus and say, is this a melanoma? And here's the mnemonic from the Shields. To find small ocular melanoma. If the nevi is increasing in thickness, it's probably transforming to a melanoma. If there's subretinal fluid, if there are symptoms like flashing lights, floating objects, scotomas, pain, it's probably a melanoma, even though pain is pretty low. Does it have lipofuscin or lipofuscin over the tumor? That's the O. And is the tumor margin close to the optic nerve? If you have one of them, you probably could watch it. I would be very scared even if I had subretinal fluid, I would get it out. But so you have to, each case is different. But the other thing to look at is the bottom, using helpful hints. This is the addendum from the Shields. If you do an ultrasound, it will be hollow. The melanoma will be hollow. And there usually is a halo that's absent. Chirpies, congenital hypertrophies of the RPE tend to have a depigmented halo. These do not. So any one of these should make you suspicious that I have a transforming nevus turning into a melanoma. And to catch it early is the key. That is the key. So please, if I could give you one bit of another clinical advice, just one more. When you find these nevi, you see this mnemonic from a court of law standpoint, I would put some of these in. It's not elevated. I don't see, or if I didn't find, my OCT didn't pick up any subretinal fluid. The patient had no symptoms. There's no lipofuscin, and the tumor margin is not close to the optic nerve. The Shields feel that anything that is within 1 disc diameter is considered close to the optic nerve. Okay.
Carlo, again, to reiterate, and every time I hear this last lecture, I learned something I always knew it was a risk factor. Is that because, again, it's not lymphatics, but it's going to use the venous system to get it out of the eye and into the circulation?
That's correct, Greg. Yes. Yeah. The eye, the lymphatics of the eyeball, very, very small amount, if any. It's very interesting. Whenever Greg brings up a good point, when you all deal with uveitis, when the antigen is in the eye, inside the eye, it doesn't go, it has to go to the spleen to be presented. And then the spleen is going to do what it has to do, and then it's going to come back up and give you the immune response, because there's not lymphatics inside the eye. It's not going to go to the preauricular. It's not going to go to the submandibular. There are lymphatics outside the eye. Those are called follicles and papillae. Those are the lymphatics on the outside of the eye, but the inside of the eye has very little lymphatics. And I say a little because some of the research is showing that in the suprachoroidal space between the choroid and the sclera, there might be, where a lot of the blood vessels and connective tissue and other things are there, there might be some lymphatics there, and that is being investigated now. But to answer Greg's question, yes, these are the things that might lead to the blood spread to the liver. So keep all of these in mind, everyone. And how accurate is the clinical diagnosis? It's pretty accurate. You don't need to biopsy every one of these nevi, as I said, that might be transforming. A clinical diagnosis made by OCT, fundus autofluorescence, fluorescein, B scan, A scan gives you about 99.5% good diagnosis of a melanoma. So make sure, once again, you do the appropriate testing, whatever you have in your office that you feel is necessary, or refer it out to get those photos done and maybe a fundus autofluorescence and so forth. Get those done. And, you know, here they are again. OCT might show fluid. If you have a B scan, run the B scan / A scan to see the height of the tumor. Fluorescein angiography, we're not going to be able to do, but you could do fundus autofluorescence. And, you know, B scan, A scan. And so they're going to show you, there it is again, the B scan up at the top and the A scan at the bottom, right? Ultrasound hollow. And Greg, we're going to do after this next slide here, after this slide, we're going to do our next polling question, okay?
I'm ready.
So what I wanted to show you here is this patient that presented in 2004, a Caucasian male at 60 years of age. Do you see everyone? It's, remember, 2 fine, small ocular melanoma. The nevus is close to the optic nerve. There's one risk factor. Can you tell it's elevated centrally? There's another risk factor. You see the orange lipofuscin. There's another risk factor. This is a melanoma until proven otherwise. So I refer it out to the Shields. In 2009, he comes back and he says, you know what? I never went to that appointment. I'm sorry. Now I'm looking at him. You can see it's enlarged diameter, more lipofuscin, increase in the apex, increase in the thickness. And he might have even had symptoms. I can't remember. But I'm thinking to myself, why is this man still alive? I didn't obviously tell him that. But you see the date, 2009. In 2010, gene expression profiling was found. And that changed the whole landscape of why this man is still alive. And I'm going to come up to those genes. Greg asked me earlier, does this man have GNAQ, GNA11? Yes, he does. He's got GNAQ, GNA11 oncogenes, but now that was to turn it into a nevus. Now I'm going to go over the next genes coming up after we take this polling question.
It's been launched.
While that's going on, hold on one second, guys. I'm just going to turn. Okay.
Carlo, while this is going on, what I just realized is that, I probably met you in 1989, 1990 when we were both at Gannon University. And I think that was like 32 years ago.
Went fast, didn't it?
And you still impress me to this day every time you do a lecture. So I'm going to end the poll.
Very
here.
kind of you, Greg. You too. Thank you.
And I'll share the results.
So yes, orange pigment, lipofuscin over the lesion, right? It's a very big predictor of going into a melanoma, lipofuscin. It was just one of them. So if we move on to the next slide, and remember what I had said, I was like, why is this man still living? And remember gene expression profiling. When I say gene expression profiling, everyone, that means we're not looking at the DNA. We're now looking at the messenger RNA. We're looking at the byproduct, or RNA, I should say. So, Greg, is there anything I need to do, buddy? Oh, there it is. Thank you. There it is. Okay, so the collaborative ocular melanoma study, you see this was launched in 1985, and you can see small melanomas are 2.5 or less, medium melanomas are 2.5 to 1.0, and large melanomas are greater than 10 millimeters in height. Now, why is this important? Okay, I'm going to go back. I can't remember the height. I can't remember. Remember, most optic nerves are about 1.8 millimeters. Some people will say 1.5, 1.8, something like that. But look at this. Small melanomas were watched in the collaborative ocular melanoma study. The medium melanoma was radiated, and the large melanoma was removed. anything greater than 10 millimeters in height. But we now know also that the large melanomas with a diameter, I keep saying this, of 12 millimeters. So if you ever find a melanoma in your practice, and you know that each optic nerve size is 1.5, 1.8, you can see how many overlie that to get your diameter. These are the ones, what they did here, they tried to say, what do we have to do to keep the patient alive? And you see the small melanomas were just watched. But now they know small melanomas with the correct gene expression profile can kill the patient. So they now know that. Medium melanomas are still plaqued, and large melanomas are still enucleated for the most part. So keep that in mind. And then we'll do the next poll question coming up here. I'll let you know exactly when. So what is the radiation treatment? Well, the radiation treatment, you see there's small, medium, and large, and it's brachytherapy. It's usually what's called iodine 125. That's what's used here in the United States. Iodine 125 brachytherapy. And that's if a plaque is put on, but external beam radiation can be done as well. So you see here, everyone, here's the plaque. That plaque is gold, and you see the radioactive beads. Those are super glued in place by the oncology team after it has gone through a process of where the radiation has to be placed. So those beads can be placed in different areas to get the base and to get the apex. And I just want you all to remember this. Ocular melanomas do not respond very well to chemotherapy. They don't really even respond well to radiation. You see that amount of radiation on that plaque? You see all those beads, everyone? That thing would probably wipe out both breasts. That's how strong of radiation there is. Carol Shields once told me she has to protect herself from the neck down to her feet because of the amount of radiation that she's applying to these patients every Monday morning, because that plaque is going to come out on Thursday. So that's a large amount of radiation. And the other thing that's interesting, if there are 20 beads on there prior to surgery, there better be 20 beads coming out of the surgery, because if once they sew that conjunctiva up, they can't have that radiation stuck in the eye. So this is from behind. This is the plaque therapy from behind. Okay, so treatment depends on many different risk factors. Philadelphia, where I'm at, most of the time, they're going to get the plaque. Other parts of the country, they're going to use external beam, stereotactic. It's a little different. Here's the plaque again. It's going to provide, you see, the plaque can be custom fit, and it's a ton of radiation. I keep saying that. It's a ton of radiation to the eye. That's why patients end up with radiation retinopathy. So keep that in mind. If you've had a patient that has melanoma and you're following them, please remember radiation retinopathy can be up to 5 years or longer after the plaque is removed. Anybody that's had radiation of the head and neck can always get radiation retinopathy. We'll talk about that coming up. But this is a plaque from, as I keep saying, posterior. The shields tend to use the plaque. And if it's surrounding the optic nerve, they'll cut a little notch in that plaque, right? It's customized. Next up, you can see here, everyone, how at times that eye has to be manipulated during the plaque placement. The eye has to be pulled out as far as it can to get as posterior if needed. And it's somewhat gruesome. You can see those extraocular muscles are pushed to their max. And you can see here, obviously, the patient's dilated, but it's the eye's been positioned sometimes and as far out as it can so that you can see the blue dye of where they're going to put it. And they will always go 2 millimeters. The plaque will always be 2 millimeters more than what the tumor is. So if the tumor is at 10 millimeters diameter, the plaque will be 2 millimeters on either side for a diameter of 14 plaque. They're always going to overdo it to kill any other cells that might not be seen. This is stereotactic external beam radiation. It's just as successful. A lot of doctors will use it. However, now you're putting the radiation through the entire eye, so it may affect the lids, the lashes, the cornea, the conj. So that's why sometimes it's not used as much. External beam radiation in doses is called stereotactic, and one big dose, you heard it called gamma knife. Okay, so this is, you see the shield to protect the other eye. So what's the treatment? The plaque or the brachytherapy that's coming external beam. Now, one other thing I want to tell you, it's called the sandwich. If the plaque is put on in the back, what the shields will do, at least what I see done here, the plaque is put on the back of the eye on Monday. The plaque is removed on Thursday. They see the shields that day, Thursday, for removal of the plaque. They count all the beads. The sandwich therapy is, I just treated it from the behind with a plaque therapy. Now I'm going to do transpupillary thermotherapy, a diode laser to heat the tumor. So you got front therapy and back therapy. And that same day that the TTT is done, the transpupillary thermotherapy, Avastin, Lucentis, or Eylea will be injected to reduce the chance of radiation retinopathy, radiation optic neuropathy, and the big one that will fail the surgery is neovascular glaucoma. For those of you that have ever seen neovascular glaucoma, it's one of the things that I've seen here that makes my heart sink. They're in so much pain. And every neovascular glaucoma doesn't need an enucleation, but when they're in that much pain, they're asking for it. Most of you have seen that. It's very, very painful. So that's why they're going to get Avastin every 4 months for the first 2 years. Okay, after the plaque and the TTT has been accomplished. Now, you can see the Avastin picture in the bottom right. This is done as part of the sandwich. You see the left of a person who has, you see radiation retinopathy? It looks exactly like proliferative diabetic retinopathy, exact same thing. And what I wanted to show you up top is what's interesting. Tara McConnell, MD, PhD at UCLA, what she's doing is now putting silicone oil in the eye with a vitrectomy to minimize the amount of vascular endothelial growth factor. All right, now, that being said, we're going to come up here with another test, another poll question in a second, but I want to just go here and finish it with this. This is what's new, and this will probably be out in about 5 years, in my opinion. What is new on the fast track for choroidal melanoma is created by a company called Aura Bioscience. And what they're doing, they're taking a viral nanoparticle conjugate, okay? They're taking the nucleic acid out of the viral component, and they're allowing that to attach to the heparin sulfate proteoglycans on the surface of the melanoma. Then they radiate it at 689 nanometers to activate the drug that's in that viral particle, and it disrupts the cell membrane. And what is interesting about this had to be placed through an intravitreal injection. But now what they're finding, they're going now to a different phase of the trial where they're injecting not into the vitreous, this viral nanoparticle conjugate, but into the choroid itself. And that is what's interesting. And this will specifically target so that maybe radiation therapy and its effects, aren't as harsh. And we can now use what's called, it'll come up with a new name once, the FDA approves it, what's called AU011. So now it's injected into the choroid. Very interesting and fast tracked into the process. So let's now, before we get into metastasis, let's take our next polling question, Greg, if that's okay.
So large melanoma, bicombs, 2, 4, 2, 4, 8, or 10. Carlo, just so you know, no other questions have rolled in. The handouts were launched by Dr. Salka quite a few while back. And they'll also be in the emails, 6:45 and going forward. There's your results, Doc.
Okay, thank you. So the answer is 10 millimeters in height is the large melanoma. And more than likely, this will be enucleated, and more than likely there is metastasis already. So, okay, so thank you, Greg. Now let's look at this particular slide, everyone. Now let's look at the risk factors. Remember, we talked about risk factors that the nevus would turn into a melanoma. Now let's look at the risk factors to see if it will go to the liver. So a thick melanoma will. Symptoms tend to go to the liver. Proximity to the nerve will go to the liver, and documented growth. If you look at this scan, look at all when you look at this liver scan, look at all the metastasis, the dark spots. They're everywhere. This is what kills the patient within a year. By 15 years after the diagnosis, and you'll see why, even though I told you within a year, within 15 years of the diagnosis, 50% of ocular melanoma patients have metastatic disease. So now, guys, I'm going to remember I told you early in the lecture, I'm going to go now from being an eye focus to an to a medical oncology focus. So now we just did the diagnosis and the treatment. Now let's say, what are you going to tell the patient might happen at this point afterwards? So after they end up seeing the shields, they're going to go and make sure that nothing is going to be in the liver. And what I find extremely fascinating, remember Greg had asked, Dr. Caldwell had asked, these don't spread through the lymph, they spread through the blood, and they do. But what's interesting is once these tumor cells get in the blood, it has to go to the lung first, and then disseminated then spread out from the lung, pushed out that way. But the liver is the majority of the site of metastasis. And you heard Greg and I have talked about this subject many times. What I find also interesting is, why does it go to the liver when the liver has Kupffer cells? Kupffer cells are the other name for macrophages. Why would it go to the liver where there's the most macrophages to kill it? And I'm going to show you why coming up later. It's a very smart tumor. So remember, everyone, yes, the lungs are going to be looked at, but the liver is going to be the major focus. Now, when I was in school in the 90s, when we had a melanoma, we had to look at histopathology, and you never wanted to hear epithelioid cell. If it had epithelioid cells, it meant metastatic disease. So we had only in the 90s, we only had histo. Then in the 2000s, we went into genetic testing, and we could look at the chromosomes themselves. And we used FISH, right? Fluorescence in situ. And what they found, everyone, if you missed one of your chromosomes, number 3, or you had an increase in chromosome number 8, that also meant high risk of metastasis. So we went from histopathology to DNA. So you never want to hear epithelioid cell, and you never want to hear loss of chromosome 3. Now, remember what I said. In 2010, Dr. William Harbour, an ophthalmologist who's now at the Bascom Palmer Eye Institute, he took over for Tim Murray, he found RNA testing, GEP. And what he did was he could then, by looking at the genetic profile, he could tell you who was 1A, 1B, 2A, 2B. If you're 1A, you're probably not going to die. 1B, a lower chance of death. 2A, a huge chance. 2B, even more. So do you remember the man that I showed you from 2004 to 2009 that didn't go see the Shields, the ocular oncology team here at Wills? And I said to myself, why are you still living? It's because he had a class 1A tumor. We didn't know that at the time. Now we do. And now what's being launched is something called CUBE, the Collaborative Ocular Oncology Group. And now what that is doing, everyone, we're looking at what's called blood biomarkers. You don't have to do a 25 or 27 gauge needle biopsy. You can test it in the blood. That's coming shortly. You can test somebody to say, yes, you have melanoma cells and so forth. COOG is the new study that's being looked at right now. So now
Carlo, can you just clarify, I know you just said it, but I know this
Yeah.
confused me quite a bit back in the time. When you're doing this class 1A, 1B, class 2A, this is actually, you just said it, they're taking a 25 gauge needle going into the tumor. This is not a different type of gene expression. This is gene expression of the tumor, right?
Of the tumor, that is correct. So the aspiration occurs, that is correct. They could do this at enucleation. They could do this right before the plaque is put on, Greg. They're going into the tumor, they're aspirating, they're taking out the material, they're sending it to the Decision DX Castle Biosciences, and they're going to, which I haven't given you the genes yet, but they're going to predict, are you 1A, 1B, 2A, or 2B ocular melanoma? You never want to, you want to tend to hear 1A for your patient. That's the key. 1A is the key. But thank you for clarifying that. That's correct. Okay.
Yep.
So that being said, here's COOG again. And I want you to see what they're looking at. COOG is looking at, they're comparing 1A versus 1B. These are some of the new things. They're looking at even further genetic testing called next generation sequencing, genetic sequencing. I'm going to talk to you about PRAME here in a second. PRAME is a protein expressed on the tumor that makes you either a B versus an A. The more PRAME you have on the tumor, the more you're going to metastasize. Okay, so that puts you in, if you're 1A, you don't have PRAME. If you're 2A, you don't have PRAME. It's a special protein expressed on the tumor surface. And look at the bottom, look at the almost to the bottom, the liquid biomarker that I just talked about. If they draw blood on a choroidal melanoma patient, they can find circulating tumor cells, but that doesn't mean much. What they found is the tumor cell will bind to a macrophage, trying to kill it and turn into a circulating hybrid cell. When they do the blood draw now with an ocular melanoma patient, if they find a disproportion of CHC cells, a bunch of circulating hybrid cells versus little circulating tumor cells, the more CHCs you have, that combination of tumor cell engulfed by the macrophage, that's who gets metastasis, an increase in death. So that's going to help us big time to say, listen, you need adjuvant therapy of your liver. You're going to need an checkpoint immunomodulator. And that's what's going to keep the patient alive. Catching it early from our standpoint, and hopefully these new biomarkers in the blood come out. And finally, before I move on, everyone, what I want to show you here, somewhat part of COOG, is what's called a hot and a cold tumor. This can be applied to any tumor. Melanomas that metastasize are considered cold tumors. It will evade the immune system. It will evade it. All those macrophage Kupffer cells in the liver, it's being evaded. It's evading them. It's not allowed, the macrophages can't attack it. I'll tell you why in a second. If you have BAP1, which I have not talked yet, if you have BAP1, that's a big class 2 marker, you're more than likely also going to shut down the immune system, and they're going to thrive in that liver and then metastasize elsewhere. So if you hear the term hot tumor, means you've got a lot of cells of the immune system trying to take care of it. You've got a cold tumor, not good. So keep that in mind. I can't wait until the CHC blood work comes out because it's going to save a lot of people earlier. It's going to get them treatment earlier and save lives. Now, here's what I wanted to show you. Here's the big one. I told you earlier, the choroidal melanocyte, if it has GNAQ and GNA11, those are oncogenes. You will get a nevus. Here are the three big ones to go into a melanoma and to go into metastasis. Splicing factor 3B1, SF3B1, EIF1AX. Those will keep you in the 1A, 1B, and BAP2. BAP1, sorry, we'll go to class 2. BAP1 stands for BRCA associated protein 1. If you've got BAP1, you're more than likely going to get a metastasis. And remember BAP1, everyone, I'm going to go back. BAP1 is found on a certain chromosome that also tells the immune system, don't go crazy on me, go low and don't kill me. So it downplays the immune system. So having BAP1 not only makes you go into a metastatic and growth phase of the melanoma, BAP1 also eliminates any macrophages. And I told you earlier, natural killer cells, CD4, CD8 cells to attack the tumor. Having BAP1, not good, okay? Remember PRAME. PRAME puts you into class 1B, PRAME, and also into class 2B. That's even worse, you don't want that. Now, here's another viewpoint of it. GNAQ, GNA11. And then there's the three main tumor, remember guys, I'm sorry, you see those three? They are tumor suppressor genes. They are shut off. Oncogene up front, tumor suppressor gene. So oncogene turned on up front, tumor suppressor genes shut off. E1F1AX is a tumor suppressor gene and so forth. And Greg, this is what you asked earlier, buddy. GNAQ, GNA11 are the oncogenes that make up 95% of nevi. Now, Castle Biosciences found CYSLTR2 and PLCB4 as the other two oncogenes in about 5% of the cases. So now there's a 7-gene profile. The first 4 are oncogenes. The next 3 are tumor suppressor genes that make it bigger and metastasize to the liver. If you don't have the tumor suppressor genes, everyone, the 3 on the right, you'll probably just stay in nevus your whole life. Okay? And here's PRAME. PRAME stands for preferentially expressed antigen in melanoma. If the tumor expresses PRAME, you're more than likely, whether it's a 1A turning into a 1B, PRAME means you're in the B. So PRAME makes you metastasize more. So if you're a 1A, you're probably never going to die. If you're a 1B with PRAME, you're probably going to die. Now this is with no treatment. You're probably going to die 25 years from now. If you're a class 2, you might die in 4 years, 5 years. If you're a class 2B PRAME, you're going to die within a year. Okay, so that's untreated. So PRAME is preferentially expressed antigen in melanoma. That's what it stands for. So what do I want to show you, everyone? You know, and I'm sorry I'm giving you all these letters here, but it's just, I think you get it. Here's the cell. You see up at the top, a GPCR, that stands for a G protein coupled receptor. That's GNAQ, GNA11. And then you see the profile. RAF, protein kinase C, RAF, MEK, ERK, all of those get altered if you have an oncogene. Then you see what that does? The ERK enters the nucleus. And now you can tell the cell to proliferate a little bit and you get the nevus. But if you have E1FIAX or splicing factor 3B1 or BAP1, now you make it into this massive melanoma that will then metastasize to the liver. So GNAQ and GNA11, everyone, is the PKC, RAF, MEK, ERK in the cytoplasm. And once you get to ERK, you're now in the nucleus and proliferation occurs to the nevus. And let's just hope the patient doesn't have those 3 tumor suppressor genes. Let's hope not, and they'll stay in nevus. BAP1 and BAP1 leads to class 2A and B, PRAME negative, PRAME positive, not what you want.
Carlo,
Now,
yes. Could they have those genes, those BAP1s, and if they live a good life and maybe eat healthy, so on and so forth, they don't get turned on? Is that the epigenetic side?
Yes.
Or if they do have them, it is going to turn.
Well, no, Greg, your first comment is correct. That's very good. That's exactly right.
Okay.
That's I'm glad someone listened. That's exactly right, because I'm only joking. But what I meant by that is, that's right. The epigenetics, remember, that gene is wrapped around a histone. And there's a possibility that even though the patient has BAP1 or some of these other tumor, factors that the tumor silencing genes that are not expressed, there's a possibility, like Greg said, that if the epigenetics, which would be in this case, remember, this is a tumor suppressor gene, so you would need it to be expressed. So you would need the epigenetics to acetylate the histone tail. So you would need the acetylation to occur on the histone tail. It would open up the genome, and BAP1 can be expressed to stop. It's a tumor suppressor gene to stop it in its place. But that's exactly right. If epigenetics methylates the DNA, it will wrap tighter around the histone and it cannot be expressed. But Greg also brings up another good point. Remember, there's a possibility that the BAP1 could be lost on chromosome 3. So you don't have the ability to even turn on BAP1. So it could be a combination. That is correct. Thank you, guys. Thank you.
No, thank you.
Okay. Now let's look at the next one here. All I want to show you here, do you see, this is what we just said. GNAQ is up top, BAP1 is on your right, and then the other are on your left. All I want to show you here, they're looking into medicines to stop the GNAQ process. They're looking into medicines to help BAP1, and they're looking into medicines to help the others that you see there in yellow. So they're trying to come in at different viewpoints. How many of you have heard the commercials or seen the commercials, Keytruda and Opdivo, these checkpoint inhibitors, Uvual? Those work very well over to the left with SF3B1 and EIF1AX. Those work beautifully on that side. So you've heard Keytruda, which is a PD-1 inhibitor, with Uvual, which is a CTLA-4 inhibitor. Those two drugs work beautifully, but on the left there, for metastatic melanoma to the liver. That's all I'm trying to show you here. So this slide we've already gone over. I don't want to beat a dead horse on this, but what I want to show you, then we'll go into the next polling question. All I want to show you in blue, there are some individuals that have melanoma, but not just a defect of the BAP mutation in the choroid. It's germline. It's in every cell of the body. So 1% of all melanoma patients, it's called BAP1 melanoma syndrome. These patients will get mesothelioma. They'll get skin cancer, basal cell carcinoma, breast cancer, meningiomas, and renal cell tumors. So there's a subunit of the BAP1 class 2A and 2B that these patients can get multiple cancers. And it's germline, not somatic, just in that cell of the choroid. And I just put this up for you because I'm a visual learner. Most people are 1A, thank goodness. 1B is about 17. Remember, B means you probably have PRAME. And the 2A and 2B, PRAME positive, PRAME negative, is about 33%. So this is how the COOG study is trying to pull these out, which ones are deadly and which ones aren't. Gene expression profiling will show this. And you see the liver popping in here. The liver is the #1 site of metastasis, 90%, 90% of the liver. And it spreads via the blood. Now, to wrap some of this up, I got a few more slides and I got about 10, 15 minutes. This is the adjuvant therapy. So who gets adjuvant therapy? 1A does not. If you are 1A, that means you don't have PRAME. You're not going to get any therapy for your liver. You're going to get therapy for your eye, but not the liver. So we're talking about adjuvant therapy, so it's not going to attack the liver. If you are PRAME positive 1, class 1, that's PRAME positive, it makes you 1B, you're going to get adjuvant therapy. Uvual, Keytruda, you're going to get these meds that I'm going to show you. If you're class 2, you're automatically going to get adjuvant therapy. Obviously, the patient can decline it, but I'm guessing they want to live and they're going to get these therapy infusions for the liver. So once again, that's why I said to you everyone earlier, I'm going more into medical oncology so you can tell the patient what to expect. Here's the first checkpoint inhibitor that you see very popular now with the TV commercials. The first checkpoint inhibitor is the program Death 1, PD-1 blockade, and the CTLA-4 blockade. Nivolumab is known as Opdivo. Ipilimumab is known as Yervoy. So you got the two together. These work beautifully. They are checkpoint inhibitors. They turn up the immune system. They turn them up so the natural killer cells and the CD8 cytotoxic cells can attack and find the tumor. So that's why these two in combo work well to keep the patient alive. Here they are again, Keytruda and Opdivo. Both of these two, pembrolizumab and nivolumab, they are PD-1 checkpoint inhibitors. The other adjuvant therapy earlier in the system, I just want you to know it's a MAPK pathway. It's earlier up by GNAQ. This is selumetinib. This will also allow the immune system to try to get activated and stop some of that RAS, RAF, MEK, ERK, all of those things I said earlier. And everyone, once again, we got to find cures at the GNAQ, the BAP1, and I told you earlier, the checkpoint inhibitors work well over on the yellows on the left. All right, now that being said, let's take the fourth poll question, Greg. Is that okay?
It is launched. Hey, Carlo, maybe you don't know this answer, but if they get to the point and you're getting way up into the pathway, and we're talking about the GNA11 and the GNAQ, and they find an inhibitor, would that make your nevoma, in a sense? I know that's your word, but the nevus,
Yeah.
would it make it disappear, you think, or would it just stabilize it?
It would probably it would stabilize it. That's correct. So if it would stop that ERK coming into the cell and causing even more proliferation, and hopefully ERK doesn't modulate BAP1 or those other tumor suppressor genes. So yes, I personally think for those small tumors that are like around 2.5 in thickness, Greg, that might have two fine small ocular melanoma, maybe one or two of those, that's where the GNAQ, GNA11 might come into play a little more.
Carlo, can you comment on some of the ocular side effects or adverse events with the targeted cancer therapies such as the BRAF inhibitors?
Yeah, is the question, Joe, the side effects that occur in the eye or the side effects that occur from the adjuvant therapy?
Well, the question is being asked is the ocular side effects and adverse events. So I guess that's pretty encompassing. But I think let's look at the ocular first. Yeah,
so let's say, so if a person has an ocular melanoma that's not treated, the biggest side effect would be a retinal detachment, exudative, with following probably neovascular glaucoma. That's pre-treatment. Post-treatment, the biggest side effects would be neovascular glaucoma again, radiation maculopathy, a ton of edema, and radiation optic neuropathy. Those would be post-treatment radiation. Some of the side effects from the checkpoint inhibitors are mainly skin rashes. So those individuals who go through the checkpoint inhibitors, other things can occur, but the big one is in some patients, the side effect of, let's say, Yervoy, ipilimumab, and so forth can be this skin irritation / rashes. So I think those would be the most encompassing.
Thank you.
Thank you.
And Carlo, I'm just going to make a comment while you're looking at the reports there, just to remind everyone, when talking about biologics and you hear those MABs at the end, MAB. It's standing for monoclonal antibodies. So that those are monoclonal antibodies that are targeting these areas. So that's pretty cool stuff.
Yes, it's the future. So this is interesting. The right answer is enucleation, more than likely. But I can see why people put plaque, because even some large melanomas, usually are enucleated. Some people will try a plaque first, but the right answer more than likely is enucleation. Okay, so now I just want to continue, and then we're almost done here. Do you see the metastasis once again on this scan, everyone? All those black dots. If the Uvual, if the ipilimumab, if the checkpoint inhibitors don't work, what I wanted you to know about this, you see Dr. Sato, he's at Jefferson and he's at Wills. Sato is an he's an oncologist that deals with, he's a medical oncologist that deals with liver disease from melanoma. And if those aren't working, if you want to come to Wills out here, Philadelphia, not everyone does this. I'm just using this as an example. MD Anderson in Houston will do something different. Mass Eye near Harvard will do something different. But here in Philly, Takami, Dr. Sato is going to do one of three things. Do you remember the liver? The liver has a dual blood supply. The hepatic artery is going to bring in 25% of the blood, the hepatic artery coming off of the aorta. The portal vein is going to bring in 75% of the blood. But remember, it's a vein. It's bringing deoxygenated blood from the stomach and the intestines. So the liver gets most of its blood from the portal vein. But luckily for us, melanoma will metastasize through the hepatic artery. So what they do at Jefferson, they embolize the hepatic artery with chemo. They block the hepatic artery. The tumor comes through the hepatic artery. So they'll do chemoembolization, and they'll give the patient maybe an extra 4 years. And if that doesn't work, they'll put immunoembolization in to boost the immune system into the hepatic artery. They block it for 4 days with a sponge. That might give the patient extra time. And then they do SIR spheres, radioembolization. So they can try to extend the patient's life once the metastasis occurs. But I'll say it again, everyone, as an optometrist, catch the tumor early as you can, less likely metastasis to the liver. And I only say that because the patient doesn't always come in. It's not our fault. They don't always come in on routine exams and when they're told. But if they do, stress what we're talking about. Catch that melanoma transformation early. Now, if you look here, remember, hepatic artery is 25% of the blood. This is very interesting, and this is why the tumor is so smart. All of you have seen a uveitis. All of you have seen a uveitis. A uveitis should not occur. Even for people who say, oh, first time non-granulomatous, oh, you don't have to work it up. More than likely, that person doesn't understand immune privilege. The eye is an immune privileged site. It should never have inflammation in it. And you see all the immune privileged things, transforming growth factor beta, somatostatin, pigment epithelial derived factor. If I had an active T cell, everyone, if I had an active T cell and I drew aqueous out and I put the aqueous on an active T cell, it will neutralize the T cell. That's what it's supposed to do. That's why it's called immune privilege. Now, why did I bring this up? Because melanomas go to the liver and they incorporate the eye's immune privilege to evade all of those Kupffer macrophages in the liver. That's how it can grow. And it loves the liver because it's got a dual blood supply. So it's a very smart tumor. And you remember, immune privilege in the front of the eye is called anterior chamber acquired immune deviation. In the back of the eye, it's called posterior chamber acquired immune deviation. All of these things that you see here are found in the aqueous and the vitreous, and the tumor uses these things to evade the immune system to grow. So once again, catch them early.
Carlo,
and here's
yes, the eye is not the only immune privileged part of the body. Is that correct? Can you touch on that?
Yeah, sure. Thank you, Greg. The eye is not the only immune privileged part of the body. The testicles are immune privileged because they have to be protected from the immune system for reproduction. The stomach is actually immune privileged because every time you ate a new food, it would be foreign to the body and you would get an attack of the immune system. And the brain is immune privileged. It's a very important concept. And I know here at PCO, I don't teach in the uveitis course. I wish I did. But immune privilege is very big with uveitis, any type of uveitis. And if you understand that concept, there's going to be a reason for the uveitis. So yeah, Greg, go ahead.
I know we're getting close, but I mean, I'm not telling you to wrap this up in any way, but I'm just this is always, this, as you know, you and I have chatted about this. Someone gets a uveitis or someone gets a herpetic ulcer on their eye, a simplex.
Yeah.
And because of the flow, the flow through of the fluid through the cornea, you kill it with, Valtrex, you kill it with Zirgan, there's dead protein, the endothelial cells are pumping, protein gets pulled into the eye, right? That should not react in a sense is what you're saying, but it does.
Yeah, but it does. Yes. Yeah. And immune, that's a really good example, whether it's a herpetic keratitis or a uveitis caused from sarcoid, Greg. What's interesting is immune privilege has been overcome. Something shut all of these 9 things that are below here down. That's exactly right. That's why anytime there's a uveitis, even if it's non-granulomatous first time, you have to say to yourself, why was anterior chamber acquired immune privilege shut down? Why? Some organism, something shut that down. That's why, it's kind of interesting. Obviously, this isn't what the talk is about. And it's, obviously it could be debated, but it's really the opposite. People don't work them up. And I'm sometimes thinking maybe that should have the most aggressive. And that's just me thinking out loud because something shut down immune privilege. That's a whole debate. I'm sure a uveitis specialist would shut me down real quick with that, but it's just a thought process.
But,
you know what I mean?
But the point I want to point out is not every herpetic patient gets a uveitis, but some do. And the ones that do, their immune privilege was overcome.
That's correct. That's right. Yeah.
Okay. Thank you.
You're welcome. All right, here's the 2 cells again, the cytotoxic CD8 cells and the natural killer cells. That's what has to be boosted to find the tumor and eradicate it. Just going to go a couple things here. What's the patient going to get in the last 5 to 10 minutes? What's the patient going to get after the eye treatment? They're going to get basically an MRI of the liver. They might get a chest X-ray of a CT of the chest, abdomen, and pelvis. And then what they're going to do, depending on what class they are, the class will, if it's 1A, you probably get those things once a year. If it's if it's class 2, every 4 months. That's why the gene expression profile will show what to do from that point on. So you can see they're going to get more CTs of the chest, abdomen, and pelvis, and MRI, sometimes of the brain and liver if they're class 2, way more frequent than if they're class 1. Gene expression profiling will do that for them. And here it is again, just to show you, 1A, 1B, 2A, 2B. And we've already gone over all of this. So it's very important. Just want to show you one of the latest ones I had. Here's a 90-year-old Caucasian female with dementia, Alzheimer's, in the care of her 70-year-old daughter. And she came in, you see the sentinel vessels. She came in because she's experiencing a red eye and decreased vision. You see the melanoma that was found. You see the diameter, 12 millimeters, more than likely. That means metastasis. It's 4 millimeters in height. They wanted to enucleate, the Shields did. Because the power of attorney was with the 70-year-old daughter, they refused. You see the melanoma in a different viewpoint. Within 1 month, they were back in the office because she was in such pain with secondary neovascular glaucoma. Then they enucleated the eye. So you can see what happened here in this case. So enucleation was performed. some of you have heard about, I want to do this real quick, about the clusters. There were clusters in Auburn, Alabama, clusters in North Carolina. There was a cluster up in New York, and they wanted to see Huntersville, North Carolina, and Auburn, Alabama were studied by the Jefferson team. They went down there. They looked at the standard incidence ratio, and they found that there was, they had to look at, was something causing this cluster of these young people getting this melanoma, rapidly. And they found that the standard incidence ratio showed no significance, clinical significance in an analysis profile. So these two states did not have clusters, just in case you've read about the clusters. And so the summary of melanoma, and then our last few slides, the last 5 minutes, here we go. Melanomas are mainly in Caucasians. Genetic profiling is needed through biopsy and hopefully soon with blood markers. 25,000 cases per year. Look at the versus, that's now 32 to 75 cutaneous melanomas. Most of melanomas are in the choroid, and approximately up to 7 cases per million annually. So it's an orphan disease. Gene expression profiling has changed the way we have looked at this disease, and it's needed, and it's starting to get the money for research. And remember, histopathological in the 90s, chromosome in the 90s, late 90s, early 2000s, since 2010, RNA, DNA profiling. Let's look at some differentials, everyone, and then we're going to go to our last quiz and then wrap it up. Look at the differential. Here are 2 patients that came in. These are not melanomas. These are more common. These are metastatic lesions from the breast and the lung. You see how they're different in color. They're going to go to the choroid because the choroid has a huge blood supply. The man on the right, you see this man, he came into emergency, and when I saw him, he said, I have blurry vision, got this elevated creamy lesion. Sent him to the Shields, it's lung cancer. Metastasized to the cervical spine and brain, along with his eye. This man, don't worry about his large cupping. This man has, look, a melanoma, a metastasis up here at 10 o'clock, metastasis inferior, and a retinal detachment through his macula, through his fovea. This man has lung cancer, but he knew it coming in. The man on the right did not. Men usually say, I don't know of a cancer diagnosis. Women usually say, I do. I have breast cancer. Look, this is a one that was most recent, came in routine exam. You see the amelanotic lesion here. Metastatic tend to be not as pigmented as the melanoma. This man, upon further questioning, it looked like a metastasis. He was 54 years old. He said, recently I went to a local hospital, Temple University. They found some spots on my lung. That was 8 months ago, and I didn't go back. So you know what this is. This is a metastatic lesion. These are not melanomas. These are tumors that either started elsewhere, such as the lung or the breast. Always going to have more metastatic in your optometric office than melanomas, always. You want to build your practice, get oncology to send you those patients that have active cancer. You need to look. We need to look at those. Make sure that they're not in the eye. Here's one I found very interesting. You see the fovea's got a detachment. What's interesting is this is a man who died of prostate cancer. You see the prostate went to the eye. Why is it interesting? Prostate cancer usually goes to the bone, usually goes to not soft tissue, but it did. You see the metastatic lesion. And here's probably the most common from breast. Breast cancer tends to be metastatic like the others. Remember, metastatic lesions are not usually, they can be in one eye, but they can also be bilateral. This is a 39-year-old Caucasian female that has breast cancer, that had one breast removed. They said she was in remission. She did nothing for the other breast. She didn't remove it. And then after 1 year of remission, she came in, and look at all the metastases that are in here, multiple metastatic lesions. Do the poor man's MRI. It's called a visual field. She has a right homonymous hemianopsia. It had gone to the brain. She's still living though. Treatment for metastasis can be the same as melanoma, but it's usually cure the main cancer and the eye will be better. Not always. And I just want to show you this. Breast cancer patients, they're sharp. They're going to tell you, you know, the 3 breast cancers. This is what I'm actually looking into right now. Breast cancers are either estrogen receptor positive, progesterone receptor positive, or Herceptin. That's why sometimes if you hear triple negative, that means triple negative is no estrogen, no progesterone, no Herceptin. Triple positive, what I'm looking at right now is to see which one of these breast cancer patients is going to metastasize the most to the eye. That has not been looked into, and it needs to. So that's important. Breast cancer, here they are. If you ask a breast cancer patient, more than likely, they're going to tell you, I'm triple negative, triple positive, I'm positive only for progesterone, I'm positive only for estrogen, and so forth. And what you need to know about these metastatic tumors, everyone, breast cancer is mainly in females. You see the statistics there. And here's what you got to remember. If a patient says, I have breast cancer, mainly a female, 25% of those will metastasize within 5 years. So 1 in 4 are going to metastasize. And of those 25%, 12% metastasize to the eye. So metastatic lesions, as you can see, occur. You're always going to have more metastatic lesions to the eye than choroidal melanoma, our topic tonight. But I need to differentiate that. Here's another big differential, the CHRPE, the congenital hypertrophy of the RPE. Remember, everyone, CHRPE is in the retina, congenital hypertrophy of the retinal pigment epithelium. These do not turn into melanomas for the most part. They do not. CHRPEs, though, are dangerous when you have these football-shaped CHRPEs. These that are shaped like a football, they're probably not even CHRPEs. They're probably a form of cancer of the RPE, and it's called Gardner's syndrome. If you have more than one football-shaped lesion, you're going to think about polyps and colorectal cancer. You see this young man here? I got to tell you this story real quick. This young man is 25 years old. His mother died when she was in her early 50s of colorectal cancer. He did some research. He's Caucasian, and he said, I want to rule out melanoma, and I want to rule out that I don't have Gardner syndrome. This is what the kid tells me when he walks into the exam. He only had one of these football-shaped CHRPEs, and I'm not even going to call it a CHRPE. I'm going to call it an RPE tumor that's shaped like a football. And then he said to me, I took the picture, you see it here, and he said, what do you think I should do? I said, you have a strong family history, you got to go get screened. And he did. And he had polyps throughout the intestinal tract. No cancer, but polyps. This is what's called the Gardner's syndrome. You get colorectal cancer, you get brain cancer, bone cancer, skin cancer. If it goes to the brain, it's called Turcotte's syndrome, not Gardner's syndrome. It's just an example. 80% or more of patients with FAP, familial adenomatous polyposis polyps, have this atypical CHRPE lesion. Here's your melanocytoma, found usually in African Americans and Latino Hispanics. This is a magnocellular nevus with a 2% chance that it will turn into a melanoma. It can. Watch them the same way as a nevus. Here's another one, right? There's another melanocytoma. They tend to be on the border of the optic nerve and on the optic nerve. And then don't forget this one. This one's interesting. I saw this man, it was only in one eye. This is a combined tumor of the retina and RPE, and this is not with a melanoma. This is with a disease that could be neurofibromatosis. This is a combined hamartoma. A hamartoma is a tumor comprised of cells native to that region. A choristoma is cells outside that region. If you need anything, before we get to the last polling question, the Ocular Melanoma Society Foundation, go to them for information. You know, look at these diseases and save the patient's life. Greg, let's do the last polling question, and then I got one more slide, and then I'll take questions, or we'll go from there.
And Carlo, I was never able to know if I could do it. I added my own polling question here at the end. It looked like it was successful. So there is another one.
Oh, there is? Okay.
I added it. It wasn't yours, the one that you created, but I created one. So.
And everyone, while this is going on, if it's okay with Joe and Greg, if you think of a question later, I will give you, if it's okay with them, I'll give you my email address and feel free to email me. I'll be happy to get back to you. So
That's quite fine. So that's very nice of you, Carlo.
Sure.
So Carl,
And there
looks
it
like
is.
they nailed it.
And you have another one, Greg?
Yep. So it looks like they got it. A couple people said lung and spleen, but obviously the liver is the answer. And here comes the next one. Will you view a nevus, or what Carlo calls a nevoma, different and change the way you follow them? Carlo, I've been listening to this lecture probably now 8 to 7 or 8 years, however long you've been lecturing on it. I know it's been updated and you've folded into gene expression and all the updated treatments. I certainly like listening to this lecture myself for the reason whenever I start feeling like I should get sloppy and not follow that nevus in 6 months and yearly, measuring it, pulling out the OCT, using my fundus autofluorescence. And I can tell you, based on your lecture, I have found 2 that have converted very early. And I've always given you the credit because you're the one that taught me. But luckily they came in to be followed. So
yeah, thank you. So let's take a look. That's nice. 98% will do that. That's wonderful. Let's just look at the final 2 slides and then we can call it a weekend. But here's a slide that just gives you some information if you want to go and look a little more into this. And there's some websites here. And then I just wanted to put up some pictures with people that I've been studying for quite a while, looking at their research. I really enjoy, Will Harbour is the one who found the gene expression profile. He was at the University of St. Louis at the time. Got to give him a lot of credit for finding the BAP1 and those. Timmy Murray is still in Miami. He left Bascom Palmer and William Harbour took his spot. The Shields are up top, who I deal with here in Philadelphia. Colleen Kabula, MD, PhD at Ohio State, and Dr. Finger in New York, Tara McConnell from UCLA, who does the one who is perfecting the silicone oil, not to get the radiation retinopathy and so forth, and Peter Hovland in the Denver area. And many of these people are now part of the COOG study, looking at the blood and so forth. So these are some of the people that, if you want, this is what I do. I go in and just occasionally look to see what the research is showing. And these are the people who made the difference to save a life. And as I said earlier, my final comment is, and then I'll give you this information. My final comment is, even though there are only 2,500 cases a year of ocular melanoma, they're still deadly. Catch them early, save the patient's life. And, hopefully you will change the way you screen these patients in your practice. My email is there, cpelino@salus.edu. Special thanks to Lauren Richards, who helped me with this lecture in the sense of working close with me and doing some of the grunt work for me. So I appreciate it. And everyone, please stay safe. Joe, Greg, Vanessa, thank you for the opportunity to lecture. It's always a pleasure with you guys. And I can stay here for a while if you'd like and answer questions. Otherwise, I'll see you in June.
we have 2 questions and a comment. One of the comments is, I had a patient, or one of the attendees said, I had one patient with choroidal melanoma. The patient came in complaining of scotoma in the visual field. So just showing that they were symptomatic. The question is, does insurance help pay for genetic profiling?
That's a really good question. I'm going to say, for the most part, yes. What I would like to just expand on just a little bit is that they're going to do the gene expression profile either at the enucleation or at the time of the plaque insertion. However, it's only out of all what they're trying to find are the statistics. Out of all of the patients that have melanoma, the 2,500 to 3,000, whatever, have it per year, about 80% get the gene expression profiling done. The other 20% don't want to know. But it appears to be covered, yes.
Yes, and I've had patients that had it done, and they haven't said they had to pay for it. So here's a question from a Ganonite here, Carlo.
Okay.
Tracy from, you might remember, if you look at the Tracy Schreck up in Erie. Are metastatic ocular lesions treated the same way?
Okay, so metastatic lesions may or may not be treated the same way. If it's a breast cancer, the aromatase inhibitors, so you all know about the aromatase inhibitors, they tend to work very well, not only to remove the cancer of the breast, but because it's systemically given, they tend to actually shrink the metastasis itself. So depending on the type of cancer, the actual chemo/radiation that's given to the patient, or whatever type of treatment it is, may actually shrink the tumor in the eye as well, the metastatic lesion, and they may not need the treatment that the melanoma gets. So if a breast cancer metastasizes to the eye, but the patient isn't a candidate for the aromatase inhibitor, and they have to use another means, then the metastasis may remain, and then they will do the same thing, external beam. They may do external beam stereotactic. They may do the plaque. They may do the sandwich with TTT, and they will VEGF inhibitor them. So Tracy, the answer is depends on the cancer, and it depends on the treatment systemically of the cancer if they need further treatment of the eye. I hope that made sense.
And the last final question is genetic testing for metastatic risk. Is it a standard of care now?
Well, the blood test isn't available yet. So we're talking.
I guess it would be the genetic profiling, the gene expression.
Yeah, it's not mandatory. It's all based on what the patient wants. Mm-hmm. Yeah, so it's standard of care in the sense of what the shields will tell them. We would like to do it because then we could, does that make sense? Because if they don't want to get genetically tested, they would probably have to get the MRI, the CT of the abdomen, pelvis, and chest every 4 months, because they have to treat them as they were a class 2A or B if they don't want to be genetically tested. But that would be up to the ocular oncologist, medical oncologist conversation.
So I would say the answer is not the standard of care, but highly encouraged. So
there you go.
Carlo, you're getting a ton of thank yous. Great jobs. Dr. Sutherland was on here, past president of the American Academy of Optometry, giving you the kudos. They're starting to roll in now. Everyone knows where I feel on this. So thank you for being here. I'll do a few housekeeping. This was Ocular Melanoma, a comprehensive review by Dr. Pelino. Joe, any comments before I jump in and do some housekeeping?
No, I thought that was a well-researched, well-presented lecture combined with your extensive experience. I mean, clearly this is your Sgt. Pepper's. So it was a tremendous lecture. Thank you.
Yeah, thank you, everybody. I appreciate your kind comments, and feel free to email me. Everyone stay safe, okay? And Greg, I'm going to stop sharing, okay?
Yep, you can.
Okay,
Yep,
bye, everyone.
You can close off. Yep, thank you.
Okay, thank you, bye.